Okay, hello and welcome to this ARMA webinar for the fitness sector and physical activity providers. The webinar is going to cover an introduction to musculoskeletal health and physical activity. Next week, we're going to have a second webinar in this series talking about programs that can be delivered in gyms, swimming pools and community leisure centres. So we hope that everyone will sign up for that as well. My name's Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups to work for better services for people with musculoskeletal conditions. ARMA webinars are free to access thanks to the support of our partners, and we'd like to thank Good Boost for sponsoring this webinar. Before we get started, we're just going to find out a little bit about where you all work who are joining us today. I'm going to launch a poll, which you should see on your screens now, that just asks where you work. So if you could just quickly answer that question, and then I'll share the results. The reason we're doing this webinar today is that ARMA members are very keen on getting people active. Everyone's familiar with the benefits of activity for heart health, but they may be often less aware of the benefits to musculoskeletal health. So in a moment, we'll be hearing from two speakers who've got a real understanding of the contribution your sector can make to musculoskeletal health. But just before we get started, I'm going to end the polling and share the results. So we have the largest number of you are from the other category. So we've got roughly equal numbers from council leisure facilities, local council leisure services and voluntary organisations. And we've also got a few people from private gyms. So thank you very much for that. I will stop sharing that and introduce our first speaker, who is Dr. Benjamin Ellis, who's a consultant rheumatologist and senior clinical policy advisor at Versus Arthritis. Benjamin, over to you.
Hello. So I am just going to share my presentation. Let me just check I can do that. And hopefully you can now see the presentation.
Yes.
Yeah, there we go. So thank you so much for joining today. It's a real pleasure to be here. And what I'm going to try and do in just about 15 minutes or so is take us through together something a little bit about musculoskeletal conditions and their impact, and some of what we know about physical activity and how that can be important to support people with musculoskeletal conditions. My own background is part-time. I work as a rheumatologist, so I'm a clinician based in hospital outpatients, seeing people with musculoskeletal conditions. And I also work at Versus Arthritis, which is the charity I'm working with and for people with arthritis to support people to be able to live well. And there's lots more I could say, but I'm going to move. So what are musculoskeletal conditions? I think one of the things that happens when we start talking about these conditions is there are so many different sorts. Sometimes get a bit stuck, find it quite difficult to think about these conditions because there are so many different sorts. Actually, it can be quite helpful to group them into three broad groups, and which all have a sort of fairly common approach within each of the groups. So if I start with the inflammatory conditions, and these are conditions where the immune system, which is supposed to keep us all well and fight infections and keep us healthy, where the immune system, for whatever reason, has turned on the body, and often that involves the joints, which become painful and swollen. And one of the most common conditions here is rheumatoid arthritis, which you may have heard of. There are other conditions that affect different parts of the body. Ankylosing spondylitis can affect the spine. Psoriatic arthritis is a form of inflammatory condition that affects people mainly with psoriasis. These conditions are relatively uncommon, so maybe 1 to 2% of the population are affected, but they can happen at any age. There are about 12,000 kids with these conditions in the UK. These conditions need fairly urgent intensive treatment from usually hospital specialists to treat them. The much more common group, which here I'm calling conditions of musculoskeletal pain, affects many, many millions of people. So I've put some numbers there. Osteoarthritis, for example, we've got affecting just under 9 million people in the UK. People with significant back pain at any one time is about 10 million in the UK. FMS, which is fibromyalgia syndrome, that's around 2 million. And fibromyalgia, some of you may have come across, a condition of widespread pain felt over the whole body that can be very severe and very disabling. And we might say a little bit more about that later in the presentation. Unlike the inflammatory conditions where it's the immune system that has gone wrong, in the conditions of musculoskeletal pain, there are often significant risk factors, and as well as age and genetics, obesity and physical inactivity are very significant risk factors. And so most treatment for these conditions is about supporting people to live well, and that's often done in primary care, but clearly there's a huge role for any organizations or institutions or systems that are supporting physical activity, given that physical activity is such a risk. People with osteoarthritis can go on to have surgery, but the overwhelming majority, 75%, don't. And then I want to say something about osteoporosis and fragility fractures as well. These are painless. Osteoporosis is a painless condition unless you have a fracture, which could be from a simple fall, so falling from a standing height onto a carpet, but it could also be a bone in the back. A vertebra can break, can crack or crush just from bending over if they're very weak. There's huge numbers of people with osteoporosis with this painless weak bone, but then actually very significant, hundreds of thousands of people each year go on to have a fragility fracture. And there are a number of risk factors which are modifiable. And again, physical inactivity is a modifiable risk factor. And this is very important because the primary preventing the weak bone in the first place is very inexpensive. But actually, once somebody gets a fracture, it can be very expensive, particularly something like a fractured hip, which can be. Think a bit about the impact. We think about the impact on the individuals. We also think about the impact on the country, that we have this aging population. The older bit of the population is growing faster than any other bit. And clearly, we cannot just keep providing healthcare and fixing problems. There's lots of reasons I wouldn't want to do this. I'm thinking about society and the sort of society we want to live in and the morality of that sort of approach. But pragmatically, we cannot just keep pumping money into the treatment. We have to think about how we prevent things. And what we know is that we've got a rising prevalence of obesity, and physical activity inactivity is extremely common. There's only 1 or 2 countries globally which have begun to turn that round. We've got a world where multi-morbidity, living with multiple long-term conditions, and frailty when people are no longer able to cope with the long-term conditions they have. We know this is becoming the new norm, that people are living like this. And again, we know that physical activity, which enables people to maintain their mobility and their independence, is a very important component of addressing those conditions. A huge policy interest in that, in addressing those issues in the NHS in all 4 UK nations now. And the number of joint replacement surgeries, and although that's only, again, that is only people with osteoarthritis, almost only, about between 90 and 99% of joint replacements are for osteoarthritis, but the number is huge and it's going up year on year. And that's because we are becoming older, physical inactivity, rising obesity. So we need to do something different. This is arthritis. The legacy charities which formed from in our merger have been for a long time now promoting a public health. More about this, and in particular,
Benjamin, your microphone seems to keep cutting out. So you're
right.
Going silent. I don't know if you've got a loose connection, but.
I can put on some headphones. I'm using the microphone on the computer, but that is, why don't I stick on.
Let's see if that works better.
Headphone and see if that helps. Let me do that. Is that any better?
Well, we can hear you at the moment, so.
Right, well, let's see. I'm going to crack on and let me know how that goes. So public health approach, we have been advocating this from the charity sector for musculoskeletal conditions for some years. And this is about shifting the focus from treating problems when they start towards promoting lifelong musculoskeletal health. And it's also trying to get away from the idea of problems that require treatment to the idea that everybody at every stage of their life, and whatever conditions they do or don't have, everybody can improve their own musculoskeletal health. And musculoskeletal health actually has lots of components. It's not just about, although having no pain, stiffness or fatigue is a big part of that, but it's also about having strong bones that don't break if they're challenged, strong muscles, joints and spine that can move through the range of movements you need, stability in the joints and spine so they're not injured, coordination and balance so you don't fall and have that fracture. And actually the good mental health is a very important part of it. And there have been other webinars as well. That's not something we're going to talk much about today, but the interplay between musculoskeletal health and mental health is really, really important. There's this complex reciprocal relationship. So having good musculoskeletal health is important to good mental health, and having good mental health is important. One of the messages we have to get away from is the idea that if you have problems with your musculoskeletal, the sort of activity you need is gentle exercise. I'd love to ban the words gentle and exercise. It sends out a very difficult message. Actually, the evidence for what is most effective for with musculoskeletal problems is moderate intensity exercise. Now, it doesn't mean that, of course, we know this, that you go straight from doing no activity to suddenly off you are doing moderate. But it does mean that when we say, well, think about, maybe do some gentle exercise, we're sending a message that people should only move perhaps from sedentary to light. And really, we need to be moving people further along that journey, with the definition we use for moderate being the sort of exercise you can do where you can talk, but you wouldn't be able to sing at that pace, the sort where perhaps your skin is glowing and warm and you're just a little bit out of breath. So we need to start getting the message across that it's the moderate intensity exercise which is most helpful. Again, we've done from the musculoskeletal charity sector, we've worked on a report, and the reference is there if you're interested in this. Was a report we did jointly with Public Health England, NHS England and the Department of Health as it then was. This was understanding the different sorts of activity provision that is needed for people with musculoskeletal. Often we think, well, we jump straight to if you've got a back pain or knee pain, what you need is to see a physiotherapist to get that individualized support. But actually the public health approach says not only do we not want to do that, we want to support everybody to be able to move all the time, but it's, again, philosophically not the right approach. We need to recognize that we want to be supporting people to be active throughout their lives. So that could be tier 1 self-directed exercise with no external support, with good accessible community facilities, which could include leisure centers and gyms. But then also understanding that there is a tier 2 as well, that some people do want to or need supervised physical activity with people who can reassure them that they're doing exercise which is appropriate, that can encourage them, that can, exercising with peers that can provide social support as well. We're not, I don't think, going to talk too much about tier 3 today. That's a bit specialized, but perhaps if it comes up in the Q&A, we can look at that. So this supervised physical activity in these accessible community facilities, and recognizing the barriers to participation. And David may talk more about this, but it's not just pain which is a barrier to participation or a perceived barrier, but also people thinking this sort of activity or this sort of space is not for people like me. People like me shouldn't be here. And that's something we have to address. So again, we can come back to this later in Q&A, but there's lots more in the report. People with arthritis that we have worked with at Versus Arthritis, there's some examples here. And interestingly, what are the motivating factors? Yes, we often I come from a health background, so we start straight away thinking, well, motivating factors, pain or better mobility, but actually managing the condition is only one, and it often doesn't feature in the top. But looking good, feeling fit, having fun, achieving goals, meeting people, having friends and family that encourage you to exercise, that you can exercise with, be physically active with. These are the really big motivating factors. So when we're promoting activity for people with these conditions, we need to think much more broadly than just, oh, well, if you exercise, your pain will get better, your fatigue will improve, you'll be able to do more. Actually, sometimes those aren't the best motivators. But here we hear from two people that we spoke to. So we do have people that say, look, I don't exercise because I enjoy it, but I know it keeps my weight under control. Well, that was an important goal. But then we have somebody saying, actually, I really enjoy my exercise and I love it, but actually I do know it helps me maintain my, there's a whole mix. And there are these competing narratives for people with pains. We've got two examples here. There's Nikki and Kylie. And we have people like Nikki who perceive exercise as zapping of energy. It's going to tire me out, damaging. I'm afraid it's going to damage my joints. It might aggravate my condition. And other people like Kylie see exercise as something that's energizing and improving. And a big part for all of us in the sector is we need to also recognize sometimes, so we know the UK Chief Medical Officer's guidance is that we should be doing 150 minutes a week, although I recently heard from the Director for Musculoskeletal England that something less than 20% of physiotherapists actually are aware of all the guidance. We've a lot to do to get the guidance out there, but we're supposed to all be doing 150 vascular and then adding in strength and balance exercise as well. But one of the things that we need to emphasize more is that at levels much lower than that, you do start to get benefits straight away. And again, the community and social involvement, the quality of life, you start to get that very early on with much less. So yes, we need to be emphasizing the full benefit from the full amount, but even with relatively smaller amounts. As I head into the last few slides, I just wanted to say a couple of things about some of the benefits. So yes, with all that we need to emphasize the social benefits and the well-being benefits of exercise, while lowering the barriers and saying this sort of activity is for people like you. It is for people living with pain, and it can improve your pain as well. And here is some of the data. So for osteoarthritis of the hip, knee, or back, it's reducing pain, it's reducing stiffness, it's improving your physical function. The chronic MSK pain, that's the 2 million or so people with the fibromyalgia. It's giving you all these other benefits as well. So the benefits are there. And again, the narrative that osteoarthritis is about wear and tear, that you've damaged the joint. The more you exercise, the more you'll wear it out. This is a really unhealthy narrative. And those of us who are interested in both fitness and the medical and the clinical side, we have to bring the narratives together. So we're giving the message that joints and spines are living tissues that benefit from exercise. They have a blood supply and they have a strength that improves when you exercise, not like hinges that wear out. Said a little bit about the motivators, but understanding something here is some data as well, understanding something about the barriers. So yes, people are very worried, the pain, the fatigue, these are important. So if all our classes are an hour long and people think there's no opportunity to take minutes and then rest, then why would somebody? Because people are really anxious, people are afraid. Fear of movement and the beliefs that pain is bad and irreversible. Not to mention the cost and the lack of time. So we have to think about putting together packages that speak to the concerns of people living with pain, so people can understand and can see that the concerns they have are met. So this class or this center is built and designed, and these leaflets are written in a way that addresses just a minute over 15, so hopefully not pinched too much time. This is just versus arthritis. This is if arthritis steals from someone you know every day. We all know people with arthritis. So you visit our website to come and find more. And if you're interested in seeing what we're saying about activity, there's a link at the bottom. This is the Undefeatable campaign. I haven't said anything more about that, but that's a charities trying to promote physical activity for people with long-term conditions.
That's great. Thank you very much, Benjamin. That's a really good introduction to the topic. And you mentioned there the Undefeatable campaign, which is something that ARMA has supported as well. And that's really what spurred us on to do these 2 webinars, because there are lots of people out there getting a message from Sport England that even if you have a long-term condition, physical activity is for you and it is important, and Benjamin has just really highlighted that. But we thought it was important that when those people decide that they want to go to the gym or start swimming or whatever it might be, that you are understanding what you need to do in order to make your services and your facilities more attractive and more accessible to them. So I'm now going to introduce David. David Vo is a registered osteopath and conditioning coach and occupational health advisor, and he's the exercise project lead for Arthritis Action. And prior to training as an osteopath, David worked as a physical training instructor. So he's going to talk about how what Benjamin's just been outlining applies to the work that you do. Over to you, David.
Thank you, Sue. Thank you, Benjamin. I'm just going to see if I can share what we need to share. Can you see that, Sue? We all good?
Yep, that's all good to go.
So thank you, Benjamin. Thank you, Sue. It's a real pleasure to be here with you guys, Armour versus Arthritis. And certainly this has come, I think, from, as Sue and Benjamin have been saying, about the need to have this discussion around how to encourage more people from the fitness provider, spa, fitness, gym, activity, local providers to maybe engage more with our sector to try to encourage some more numbers and improve on, as Benjamin mentioned, that what seems to be around about 20% of people who actually do the minimum government guidelines. I want to talk a little bit today about the context of this current situation. As Sue said, I'm an osteopath. I was formerly in the services as a physical training instructor. I worked in gym settings, also as a PT, and I've been embedded in sports medical teams as part of rugby teams, etc. I've tried to bring that experience from both osteopathic world, so prehabilitation and strength and conditioning. Latterly, I've been working with Arthritis Action and trying to formulate practical and usable strengthening and exercise programs for people with pain, long-term conditions, and obviously arthritis as well. And I prefix everything I say with the fact that I also suffer with daily pain and try to manage that myself. So I try and bring that personal experience in working with people. So today I also want to talk about some of the opportunities I see are there and then within the context of the current situation. So it is the miracle cure, as we've been saying. Everyone now is more or less agreed that exercise is the miracle cure for most conditions that ail the population, as Benjamin said, an aging population. When we look at government public health guidelines and National Institute for Clinical Excellence guidelines for management of osteoarthritis, interestingly, they both include strength building as part of that. If we actually break down what this means then for the fitness industry, we all know that this means the building, the increasing size or number of lean muscle tissues, the avoidance of sarcopenia or the age-related loss of muscle mass. This is why this discussion is so important, because the fitness industry is and are the experts in building muscle, maybe for a different reason, but this is quite a timely presentation. Last week, the Chief Medical Officer released new guidelines suggesting that the strength component of accepted activity guidelines are the forgotten part. It seems to be, certainly in my experience, that people are more willing to do activities in the community, such as rambling, such as local exercise classes, than actual strength conditioning. And we're going to touch upon that, hopefully, if we have time, a bit more. But the bottom line, as Benjamin touched upon, is that it's an aging population. And this is only an issue if we let that aging population detrain. Nearly 19 million people in this in this country with some kind of musculoskeletal condition or pain. And if we dip down into the over 65s, then, 80% fail to reach that. So, really resonate with what Benjamin was saying earlier. So why is this? Well, if we look at the individual barriers to exercise, I think we all know that a lot of this is to do with fear. Certainly anyone who works in this sector, working with people or clinically, it's fear of movement, fear of further damage, etc. What I call the isolated millions of people who maybe want to engage with public health advice, but have detrained due to illness or condition and physically can't do it. This loss of confidence and lack of advice, obviously. And this is really relevant because in regards to the greatest indicator of if someone's going to need help and residential care is, can you do a squat? Can you get on and off of a toilet? So can you do a squat? This is why this conversation is so relevant to the fitness industry, because this is their territory. So we've been alluding to pain and the fear cycle. So the fear of movement, fear of pain, we move less, we detrain, and that joint becomes weaker. We all know now from evidence that a detrained joint will feel more pain. A trained joint with strong muscles around that joint will feel less pain. So this is a key part of probably the day-to-day for both Benjamin and I, but certainly the work we do with Arthritis Action is try to help people to self-manage their pain by getting them moving, get them exercising, and going further to getting them to do strength training when they don't associate themselves with someone who can do it. So more deep-rooted societal things are all there. People don't associate or identify with the messaging currently out there. I do think we need to improve the nuancing of the messaging. And pain, musculoskeletal conditions and aging in today's society, frankly, are seen as negative. And so people maybe not that keen to engage with a gym. Certainly for the gym provider, for the corporate sector, for the activity provider, link workers who refer and do social prescribing. I think that there is a fear at the other end of that social prescribing pathway that if someone comes along with a complex need or medical needs or with persistent pain, then there is an anxiety and a fear on the other side of the providers, because they possibly understandably have a fear of reputational loss, litigation, fear of further injury, etc. And this was borne out by the fitness industry's own research in 2018. 80% of fitness workers or fitness industry workers felt that they were underconfident in treating someone with a complex need or disability. So we can see then that there's a slight issue from both sides of what we might call the referral. So the opportunity then, well, if we remember, we've got to try and remember, all of us got to try and remember that muscle and strength training is key to this discussion. There's an opportunity out there, which I pulled up some information here from the Global Wellness Institute, that there's a huge market out there. And I think what our sector, as the third sector, have to be, we have to wave the banner for the opportunity to invite collaboration in from the private sector, fitness providers, and local community providers, in that there is an opportunity here. I think one of the main things moving forward is to try and expand the offer and nuance the offer of fitness providers, spas and gyms, etc. In that it's not just about movement, as Benjamin touched upon. It's about immunology. It's about having a better outcome in most comorbidities of life. Interestingly, some research to come out from Birmingham University last year was talking about the musculoskeletal system or organ as an immunological organ in its own right, which is really interesting. I think we're just beginning to understand why having a healthy muscular system actually helps people with longevity and healthy aging. If we look across the world at places called blue zones, which are places that seem to have a higher than normal percentage of people with health span, longevity, and better quality of aging, places in Mediterranean, places in Scandinavia and Japan, they seem to have a good balance between nutrition, community, strength, and therefore longevity. 75% factors are modifiable. Only 25%, it seems, of factors are genetic and actually predisposing us to poor health. So there's 75% which is modifiable, which includes diet, nutrition, as Benjamin touched upon, mental health as well. And key to this is community. But to access that community and not be one of those isolated millions, which I touched upon, we have to have muscle, because muscle is the key to better pain management. Work of Lorimer Moseley points this out, that there seems to be an association between movement and better pain management. But to move, we need skeletal muscle. If we don't move, we don't access communities. If we don't move, we don't access all the wonderful work that's being done by local providers of activities for people with musculoskeletal conditions. We need to make sure they're strong enough to even get there. And I think this resonates with what Chief Medical Officer was saying, that often these guidelines and the key muscle is forgotten. So fitness industry, exercise providers, local communities are key to this. If we learn the lessons from the blue zones, they can be the catalyst. The fitness industry 100% can be the catalyst to helping people build that muscle. They are, after all, the experts in building muscle, primarily historically from an aesthetic perspective, but certainly we can actually just change that offer and focus it more on social health. So is the fitness industry ready? At the moment, I think a lot of people are doing some fantastic work, but I think there's room for improvement, and hopefully some collaboration between our sectors and the fitness industry can improve that. Obviously, for the individual to kind of reverse and overcome fear, creating opportunities to increase confidence and targeted advice and more nuanced messaging, if we break down the agiotypes that have been identified recently during some recent research. I think we need to absolutely increase the confidence and the ability for fitness providers, fitness settings and health club settings to better manage and support people with any kind of musculoskeletal condition. And this would include developing staff training and messaging. So I feel passionate about this because I've done this. I've collaborated and worked with other people before in the fitness industry and tried to bring some of those actual steps across. So drawing upon some of that experience, what that would look like to a fitness provider or someone who provides services for either the aged or for people with long-term conditions, would be firstly to recognise the opportunity, understanding the audience, as Benjamin has said, primarily an ageing audience, but certainly those can be affected, the young can be affected with musculoskeletal conditions as well. Providing a strategy, developing the strategy around that understanding, which is basically environmental. So you need to look at the environment, you need to look at your staff training and look at your messaging and try to nuance that messaging so that the examples such as Benjamin gave, people identify more and buy into it, because it's not one size fits all. Implementation, and then obviously successful ensuring ongoing relevance by diligent reappraisal. So a very quick, if I have time, case study into how this has worked before. Last year, I worked with an organisation called Wellness, who specialise in going in and training fitness advisors to go into retirement homes or to go into sheltered accommodation and work with people. And they wanted to do something, some content around arthritis. I took this as an opportunity to do some strength and conditioning, some full-on strengthening. And I wanted to create something that whichever point of ability you're at, whether you're in a chair, whether you're semi-standing, semi-assisted or freestanding, there was something for you. So I developed something that was progressive and I felt challenging. But at one point in speaking to Ben Wilkins, who I think you'll hear from next week, I was wondering whether it was going to be too progressive for a population who hadn't done strength and conditioning before, didn't identify with it. So this is an example of what it would look like in real time. So 3 basic layers. This was for hip, knee and spinal arthritis. And this is what it would look like on the a tablet that the instructor would develop it with, or deliver it with, sorry. Interestingly, and rather surprisingly, if not shockingly, the feedback we got was overwhelmingly positive. And the main thing that stayed with me is that level 4, a harder level, was requested, not by the instructors, but by the participants. The average age of these was 74 years old. And I found that truly inspirational, because there was an isolated community who had never been given strengthening conditions before, who wanted something harder. They were so appreciative of the gains that they made. And this is a population, let's face it, who even a small gain in functional strength could mean the difference between an independent or a non-independent life. So I would just like to end by saying that, I think we all feel in our sector that some more collaboration is needed. I think that the benefits will be a healthier nation, and if we can leverage some of those lessons learned from the blue zones across the world, then there'll be more health span and certainly decreased pain across an aging population. The benefits that the private sector will gain is a more engaged, loyal customer for life. And certainly I know that Benjamin and I will be very interested to have some further conversations with anyone who this resonates with in the fitness provider world. And I'd like to leave it there. Thank you.
That's great. Thank you very much, David. And you can see there's some links and references on the slide there. We will include all of those links in the email that we send round after the webinar. I should get that probably on Monday. We've got a couple of questions coming in, so we'll move to those in a second. Benjamin mentioned tier 3 interventions in his presentation. That's kind of what we're going to be covering in the second of these webinars. The escape pain was on Benjamin's slide, and escape pain will be part of that, talking about how gyms, leisure centres and pools can be involved in some of this. And I will put a link into the chat box while we're answering the questions for anyone who hasn't already signed up. But let's move to the first question, which I think is one that comes up a lot. It could probably be for both of you. So it's, should we be confident in signposting people into community activities without qualified instructors? If yes, how can we build the confidence of referral partners? If no, what levels of qualifications should community activities have as a minimum? Any thoughts on that?
I'm happy to make a start. I think it's not a simple answer, but if I had to give a simple answer, my answer would be yes. I think that part of what we have to be encouraging both as clinicians and society is for people to read their own symptoms. And so saying to people, what is it you would like to try? And if somebody says, well, I would like to try doing this, or I'd like to try this particular class or something like that, saying, great, here's some thoughts and some advice about how you might do that. And if you're finding it too much, then come back and we'll have another conversation. The pyramid approach was never meant to be a pathway for people to follow. Somebody's on the messaging saying they can't hear. Can others hear me? Okay, oh, Sue, you're muted. Okay, I can see Sue mouthing. I can hear you, but
yes, I can hear you fine.
So it's not that, but I think these are about shared. If we're speaking to an individual person, it's about a shared conversation. So if somebody wants to try walking or try park run at their own pace, great, go for it. If it's not working out and they're getting more pain, then saying, okay, well, maybe what you do need to do is some muscle strengthening, something a bit more intensive first. Somebody might go to a Pilates class and it works brilliantly for them, and somebody else might go to the same class and find it doesn't work for them, but a Tai Chi class works for them instead. So I think listening to our bodies and encouraging people to try different things. And the first thing we try might not be the best thing for our bodies, but that's okay. There is a place for people with lots of training, but not everybody with a musculoskeletal condition has to be terrified of doing something that doesn't have a highly qualified instructor.
Did you want to add anything to that, David?
I agree with Benjamin in that it doesn't have to be a clinician, physio, an osteo, or a medic. I think that it's hard to answer. I think that one of the parts of that question was, is there a minimum qualification? I don't think there is, because I don't think also there's the slight challenges that not one size fits all in terms of activities, local classes, etc. I think what works well for one person might not resonate with another. I think what I would say is that I think whomever the provider is, it's always worth having a conversation with that provider. So if, as someone who's referring, or a link worker referring to an activity, giving the information across, that link worker actually having a conversation with them and posing the questions that potentially a participant might ask. Some practical stuff about, is there parking nearby? Are there people of this level of mobility already participating? I think, having spoken to some link workers recently, there is a slight hesitancy and a slight nervousness around really complex needs and really complex medical needs, or someone with a profound musculoskeletal condition. But there's always something that can be found to benefit them. I believe that certainly just some information that can be found on either our website or on Versus Arthritis website about activity, and starting off even at a low level at home to enable you to then access the community. What we don't want to do is disappoint people by sending them somewhere and them not being able to do it. So I do think that there is an opportunity for our sector to provide a bit more training to the layperson or the fitness provider, fitness professional providing local community activities. And from that point, as Benjamin will probably agree, once you've had training, it comes with experience. I think in 80 to 90% of the people I see in clinic, 10% of them probably need to be told to take it easy or maybe a referral somewhere, but 90% of them will always benefit from activity and a bit of strength and conditioning. But it's having that confidence to do it. And I think that maybe education and training can be of benefit to people who are in the local community setting.
I think I agree with everything there. I think when we're dogmatic as well about do this and don't do this, it sends a message. The message people hear is exercise, physical activity is risky, it's dangerous, it might be harmful, be careful. Yeah. And that's the opposite of the message we want to promote. And if someone wants to try swimming, go for it, try swimming, see how it goes. And then if they're struggling with that, that's when the question comes, okay, what sort of instructor, what sort of level of support does that person now need to be able to do that activity, or support finding an alternative activity? But overwhelmingly, the message needs to be exercise is safe, listen to your body, and do more. Which sort of leads us on to the next question.
Yep, I was just going to briefly say, because David mentioned link workers, just in case anybody doesn't know about link workers, these are the people in primary care services who do what's called social prescribing. We'll talk a little bit more about them in webinar 2, because there is no point you working hard to get a really good offer for people with musculoskeletal conditions if those people don't find out about it. And one of the ways to do that is by engaging with your local link workers. So that's another plug for webinar 2. But yes, leading on to the next question, which is, I speak to a lot of people who say it's because of exercise. They have pain, like I've played tennis all my life. So they're very, very dubious about me telling them that physical exercise will help improve their condition. How can you support someone like that?
So the question is, how can you support someone with pain?
Well, how can you support someone with pain who says it's because I've been doing exercise that I have the pain? So it's all the people who say, because I've been running all my life, that's why my knees are now hurting, or it was the rugby injury that caused it?
I mean, of course, there are certain musculoskeletal conditions that are caused by historic injury to do with sport. But I think, the benefits of keeping moving and doing activity for the majority of the population outweigh any risks associated with doing sport or doing any activity. I think those who are training with or trying to stay active with pain, you sometimes as a clinician have to have a very frank conversation with people to say you're going to have pain, but the choice is you have pain, you try to manage it, and you stay strong within that by exercising, by pacing yourself and listening to your body, and exercising intelligently for yourself. Or the pain dictates that you become immobile and you detrain, and then you're into that vicious circle that I shared with the slides, that you detrain. And you get into that cycle of not being active. So by far, the benefits of exercise and sport outweigh any risk, either historical or forthcoming.
Did you have anything to add to that, Benjamin?
No, I think I'm pondering. I think that's right. I think it's very if somebody has a fixed view that a particular thing has caused them a particular thing, running, I've ruined my knees, tennis, I've ruined my shoulder. It probably isn't true, although it may be. If you've injured yourself, that may be the case. But I think you then have to move the conversation exactly as David said. Okay, well, given that's how you feel, what is it you'd most like to do to maintain the movement you have, to keep as well as you can? Because not exercising, you would have something I sometimes find myself. I think you might feel that your knees are much worse because you used to run every week, 3 times a week. But actually, people that don't run tend to be worse off than people that do. And actually, you're probably heading this way anyway. And running's probably meant you've got it later in life than you would have done otherwise. But you have to work with people's beliefs where they are, I think.
Great, thank you. And then we've got a couple of questions here about directed at David about the course. So did you find that there was initial work needed to increase the carers' own awareness about physical activity before supporting their residents to engage? And it would be good to know how the OAS, etc. steps fed into the development of the project. I'm hoping you know what that means.
Well, the first bit, I'm not familiar. Someone could tell me something about OAS. I'm not sure what I'm talking about. I've certainly developed that in line with. So with they have a network of instructors who are lay people who they train via a face-to-face training. I think a 2-day training course. So anyone who becomes an instructor with has a training course. I think it was actually part of the Sport England approach to trying to reach as many people as possible in a scalable project using technology, so iPads, etc. So I fed into their repository of programs. So basically I provided the strength conditioning component for 3 areas of the body at 3 levels of intensity. And so work very closely with to provide moving images and instructor instructions to make sure that the instructors, or I think they call them fitness advisors, were able to deliver that. So it's algorithm based, but the content itself was provided by me, the algorithm and the and so with, in effect, acting as our agent really in old people's homes, which is a fantastic, I think, model of maybe some future. If the person asking the question can send the information, I'm not too sure about that actually.
Oh, the OAS was the initials of your steps towards planning a new initiative.
Oh, I'm sorry.
That was shorthand for your slide.
ACES, yeah. So yeah. ACES, I thought OAS, and I sent a bill. So ACES is something that I've taken from. It's just an easy way for people to understand. I work with other organisations, so I did a health promotion project with a certain organisations such as National Youth Orchestra, other performance-based organisations, rugby teams. I would use that to break down the stages, and that gave an example of helping someone to understand what it would look like if they consulted with people in our sector. And depending on what you're already doing, the messaging you're doing, the content you have, the staff training, your environment, you would come in somewhere on the oasis at some point along it, depending on where you were already. So there'd be a landing point for everyone on that.
Okay, brilliant. And then we've got a question which I think Benjamin's engaging a bit in the chat box. So from a leisure perspective, we do have very well-established activity on referral programme, but often struggle to raise awareness with GPs and medical professionals to refer to exercise programmes rather than issue medication. How do we change this awareness within GP practices?
I think it's wider. So Scott, I've just asked you, I don't know if you've seen, but it'd be really interesting to know what you've already tried. My thought is that raising awareness is probably necessary but not sufficient. And this is, if there was an easy answer to this, we'd have answered it and we'd be sorted and we could all go home. It's really difficult, and it's got to be a big part of a partnership. So I think that no one organisation, no one bit of the health and care and public health system can do it on their own. It needs to be clinicians, the people living with long-term conditions, public health providers, and so on, coming together and exploring what the wider offer is beyond drugs. I think there is a movement towards this. We mentioned link workers, and there's going to be more about that in subsequent webinar, but that is part of the story. But I think no amount of leaflets and web links and this is what's available on its own will be enough. The whole system of how we think about how we support people with long-term conditions needs to change. And I think the most important thing one of the important things that the leisure providers can be doing at the moment is making sure that their part of the offer is ready, that there's been lots of work together with people living with the conditions that they want to arrive at, that there's been in developing the physical environment, the website, the promotional materials that are used, the language that's used, the images that are used, all these sorts of things that demonstrate that, and both David and I have used this term, this facility, this space is for people like you, and having that readiness. And it feels at the moment that the health and care system is on the cusp of really starting to engage with this. And what we need is all the partners to be equally ready. So I would say keep up trying to engage with individual practices, with primary care networks, with integrated care systems, with all the pieces, with your local public health teams, and the opportunity is there. But all of us, and I say this as a clinician, we all have to get our own houses in order to be ready for this to happen, and that is necessary, but it won't be sufficient. This can only happen in partnership, but a big yes to loads and loads of involvement of people with the long-term conditions that you're trying to reach.
And I can see lots of people putting stuff in the chat box about the importance of public health, and Public Health England doing some work on this. And the other thing I would say, since we've come on to the subject of link workers, so link workers are just being rolled out at the moment, so there aren't necessarily huge numbers of them at the moment, but there will be increasing numbers. Their job is partly to work with people to find out what are the different kind of social activities and things in the community that might benefit them. But the other part of their job is to know what there is in their local area. So actually a lot of people say, well, we're doing these marvellous things in our gym or our pool or whatever, but how do we tell the GPs about it? Because everybody says, oh, GPs are far too busy and they're very difficult to engage with because of that, which is true. But actually, once you have link workers in primary care, you will have people whose job it is to know that you have something useful to offer in your gym or your swimming pool or whatever your facility might be. And therefore, if you go and talk to them, you're actually helping them do their job. So I think they are going to be a key way of getting into the NHS, as well as all the very valid things people have been putting in the chat box about public health and the importance of public health.
And we shouldn't underestimate the ability of the industry and leisure providers to reach out directly to people with the conditions you're trying to reach, and say, and by the way, if you want to get this through the health service, go and see your GP and ask for this, because people power is powerful. And if people with arthritis or other long-term conditions have had good experiences in your facility, they will be telling their friends and family, and they will be telling their friends and family, and they will be going to GPs. And GPs, clinicians, we can fold pretty quickly when people come in saying, I want a tablet, I want an injection. But when people come in and say, I'd like a referral to this leisure provider, I know it's available because my friend Betty got it, then actually it's very easy for the GP to do what wants. So all of us have a role in charity sector, in the leisure sector as well, in encouraging the public that the thing to do if your back hurts is not to go and see the doctor. Your first stop should be somewhere where you can exercise. And if when you go there, you find out, oh, you can have 8 sessions free if you go and speak to your GP, that is a route to make that happen.
So I just like everything Ben said, I agree with. I think that we've recently started to try and formulate a directory of local providers, which manual workers, physios, osteopaths, GPs can confidently refer to. We hope that this will be something that grows. It does seem to be in research in the directory of exercise providers, there's a real postcode lottery. There's a lot of people doing some fantastic stuff in local authorities, but you go to the next local authority along and there's not much there. So there needs to be a centralized movement. I think we need to have much more collaboration. As Benjamin says, people power is the way forward. And I think that increasing the confidence of the fitness providers to provide more and more and more in the community, and so that a gymnasium, a spa become the new community hubs, not a health centre. And I think that's the way forward. And I think that comes from a lot more collaboration between people like ourselves and people in the fitness industry and private commerce.
Yeah, which I think we've coming towards the end of our time. We've come to the end of our questions. That's quite a good note to end on, because I think it is going to be moving in that direction increasingly. And I think everyone on this webinar will be part of helping that move until it gathers steam and becomes the norm. So it just remains me to thank you both for presenting, to thank everyone who's joined the webinar and got involved. I hope you found it useful. The recording will be available online shortly, and you should get a link sent to it, and that email with the link will also include a link to sign up to next week's if you haven't already done so. So thank you very much.